Okay, thank you, Dr. Fajardo. So now, having discussed shoulder ultrasound, we're going to move to some shoulder interventions. I'm just going to discuss a few general concepts, and then the specific procedures we'll talk about today are going to be the biceps tendon sheath injection, a glenohumeral joint access, whether it be for injection, arthrogram, or aspiration. We'll talk briefly about the acromioclavicular joint, the subdeltoid bursa, and lavage for calcific tendinitis. This is not a complete list of shoulder interventions that you can perform, but should give you a good approach to others if you need. So first of all, if you're asked to do any procedure, the first thing you need to ask is it indicated? What is the diagnosis? What's the clinical history? You're going to want to look at every available imaging or laboratory study to try to figure out what's going on with this patient. This is a recent example just from the past couple of weeks. An 80-year-old female, left shoulder pain. The radiograph demonstrated a suspected lesion within the proximal humerus. Okay, a bone scan was performed. You can see the little warm lesion up in the calvarium, and the nuclear medicine physician that read the examination said, you know, I don't see anything that's hot in the humeral head on the left, but there might be a cold lesion, and brought up the possibility of myeloma. At this point, the oncologist called me and asked me for a biopsy. I looked at these images and said, hold on there, cowboy. Let's look at whatever else we have. We do not have any other cross-sectional imaging other than a chest CT. In a chest CT, the arm is typically raised up over the head. So this is the chest CT. We just get a few images of the humeral head. Looking at this, you can see the marrow fat within the epiphysis of the humeral head, and you can see the proximal humeral metaphysis. And where's the lesion? Does anyone see one? Neither did I. I called him back and said, you know, I don't think there's anything there. Let's get an MRI and we'll prove it. And so we got the MRI, no lesion. So just be careful. You want to look at all available imaging studies. In some cases, it might behoove you to get another imaging study. Please don't biopsy it unless you have to. If you do decide to perform an imaging study, the next thing you need to ask yourself is, how am I going to do it? What imaging modality will I use for guidance? The top image is a fluoroscopy machine. Am I going to use fluoroscopic guidance? Am I going to use ultrasound guidance? Perhaps CT guidance to put my needle into the joint or body part or lesion? What will be my approach? What will be my technique? These are all things you need to figure out ahead of time before you step into the room with the patient. If you're going to perform a tumor biopsy, I would also warn you that there is good literature out there that would support, and we'll talk about this tomorrow when I do another lecture on thigh and knee procedures. If you're going to be if it's going to be a biopsy of a lesion that could be a sarcoma, that biopsy needs to happen at the place where the definitive treatment will occur. And by definitive treatment, I mean the excision, whether it be a wide excision or a marginal excision, the radiation, the chemo, that needs to happen as a team at the center where the definitive treatment will occur. If it's not going to happen there, don't biopsy it. Okay? Have you discussed your biopsy with the orthopedic oncologist? And specifically, one of the things in that conversation needs to include where your needle is going to go. If it's a sarcoma, that matters. An erroneous place of a needle for a sarcoma will change the surgery and could change the patient's prognosis. When are we going to use ultrasound for guidance for needle procedures? We're going to use it if we need real-time visualization. Ultrasound is great for that. There's no ionizing radiation. We can see in real time the surrounding tissues, the target, and the needle. If you're in a deployed environment, this comes up. If you're in Afghanistan or Iraq, for example, you're not going to have MRI. You may not have fluoro. They may have a C-arm in the OR, but it may be difficult for you to obtain in some of the situations where you'll be in, and ultrasound may be your best bet. If we're going to do cyst or fluid aspiration, tendon sheath injections, or if we're going to combine it with Doppler or dynamic evaluation, similar to what Dr. Fajardo talked about, ultrasound is going to be the modality of choice for those things. In a pediatric patient, we often default to ultrasound because of the lack of ionizing radiation and because we don't need sedation. And you can use it if you have a severe allergy to contrast. Okay, so here's the first thing we're going to talk about is the biceps tendon sheath injection. When do we do this? Typical indications for biceps tendon sheath injection include pain due to inflammation of the biceps tendon. Basically, some authors would advocate only performing a biceps tendon sheath injection after failure of all conservative measures. However, I'll tell you the common practice is to do a diagnostic and therapeutic biceps tendon sheath injection, where you try to give therapeutic pain relief, but also you're getting some diagnostic information. If the pain goes away, then we know the biceps is involved as a component of their pain. If the pain does not change, then their pain's coming from somewhere else. This is a very common practice for this type of injection. Just so you know, they can certainly do this in the clinic. The clinician can feel the bicipital groove and put a needle in there. The advantage we have in ultrasound is we can see the tendon. We can prove that the needle was where it was supposed to be. So if their pain doesn't go away, at least we know that it's not because we put the needle in the wrong place or because their tendon wasn't in the right place. Some common risks for any needle procedure include pain, infection, bleeding, or potential allergy to the medications that are used. You're putting a needle right by the biceps tendon, so injury to that tendon or adjacent structures is something you'll talk to the patient about. And we talked about the potential lack of pain relief. With regard to the corticosteroid injection, first of all, you don't want to do an intratendinous injection. It's been shown there's a high percentage of localized necrosis when you do an intratendinous injection. What we want to do is a peritendinous injection in the tendon sheath. These, in the immediate term, cause no biomechanical or histologic damage to the tendon, although there is some evidence that repeated injection could potentially weaken that tendon. Why do we inject steroids? First of all, it has been shown histologically that the early inflammation process is inhibited by the steroids in the form of edema and fibrin deposition as well as capillary dilatation. And then also later manifestations of the inflammatory process are reduced by the steroid. What medication and what dose do I inject? The available literature in this regard is scanty. This is in your syllabus, so I'll let you do some reading about this. There is evidence that the fluorinated corticosteroids are more likely to have some subcutaneous atrophy associated with injection, although this does recede with time. There is also evidence that the phosphate types of corticosteroid are more soluble than the acetate types. And so these are often used for more acute conditions, celestone being an example of that. Those with lower solubility typically have a longer course of action and are more commonly used for chronic conditions. Okay, the radiographic anatomy of the bicipital groove, you can see the lesser tuberosity and the greater tuberosity. In the normal setting, the biceps tendon will run in between those through the bicipital groove. Here's an ultrasound transverse image showing the biceps tendon within the bicipital groove, and Dr. Fajardo very nicely showed how to find this and image this with ultrasound. With the patient supine, with the hand supinated, this is right in the front of the proximal humerus. For the biceps tendon sheath injection, we will typically do a freehand technique, the transducer in an axial orientation at the anterior aspect of the proximal humerus with the patient supinated, supine. We use a lateral to medial needle approach. The needle looks like this. Here's your needle approaching the biceps tendon sheath. You're going to aim for the base of the groove. As you test inject, either saline or local anesthetic, you can see the tendon sheath begin to fill. And now I'm injecting the corticosteroid mix. You can see it's mildly complex because of the echogenic steroid that's within the mix. And there it is. After the tendon sheath injection has been done, you can see greater distension of the bicipital groove, or of the biceps tendon sheath. So here's one tip that I have found useful, and this is called fluid dissection. This technique will allow you to displace that tendon out of the way of the needle so you don't skewer the tendon. And so what you do in this situation is you place the needle right up adjacent to the edge of the bicipital groove, and as you test inject, you see that not only am I filling the bicipital groove, but I'm actually displacing the tendon away from my needle tip. A little bit more injection, you can see the biceps has now been displaced medially, and it allows me a window to put my biceps, or to put my needle into the base of the groove underneath the tendon. I've not skewered the tendon, I've pushed it out of the way. And this allows me room to do the rest of my injection. Okay, so fluid dissection can be very useful for this type of procedure. Here's another tip that you can use. Angle the transducer. Many times with these linear transducers, depending on the obliquity of the angle of approach of your needle, it may be difficult to see. The closer your needle is to parallel to the face of your transducer, the more obvious it will be on your image. The closer your needle is to perpendicular to the face of your transducer, the more invisible it will be on your image. Okay, in this case, it's a rather oblique approach. You can see I'm having difficulty seeing the needle. A simple change in your position that allows you to leave your needle without having to replace your needle. You simply change the position of your transducer to make it more parallel, and now I have a better visualization of my needle. Keep in mind, it does change the appearance of your target, but as long as you can keep your target in view and your needle, you can get it there. Okay, we'll move on now to the glenohumeral joint access. Corticosteroid injection for the glenohumeral joint is typically indicated for osteoarthritis of the joint, adhesive capsulitis of the joint, or inflammatory arthritis of the joint. We also use glenohumeral joint access for arthrograms routinely for CT or MR, especially MR, or for aspiration. Again, typical risks that you would have with any needle procedure, so I'm not going to go over those again. Let's talk for a minute about corticosteroid and anesthetic injection into the joint. This is a growing body of knowledge that is going to have an impact on your clinical practice. So I would be aware of the literature in this area because it continues to grow as we speak. First of all, this first article just came out within the last month. Intra-articular triamcinolone may be toxic to human chondrocytes. This is important for us because I'll tell you, up until now, we've most commonly injected triamcinolone into the joints. So this may change what medications we are going to use routinely here. It has been shown also that intra-articular bupivacaine especially, and to a lesser extent lidocaine, may be toxic to human chondrocytes. And finally, the combination of triamcinolone and bupivacaine may be toxic to human chondrocytes. So what am I going to use? Well, there are a number of different anesthetics that are available that we may be able to use. Ropivacaine is a local anesthetic that has not been shown to be toxic to chondrocytes. It is about, 6 or 7 times more expensive than lidocaine, but is a potential option. And you may also consider performing saline mixtures of corticosteroid into the joint. It does take away that immediate gratification of the patient moving their shoulder around and saying, "Oh, I don't feel any pain at all, doc." But it does allow you to stay away from this type of thing. So when we're going to do the glenohumeral joint injection, there are various techniques. I'm going to show you only one. We've been using this technique only for a relatively short period of time. In our local experience, the clinical accuracy, well, let me say this, the clinical accuracy of this technique in the literature is not published. In our local experience, our unpublished data of about 35 cases, we've had successful joint access 34 out of 35 times as proven by intra-articular gadolinium contrast on MRI. So we have about a 97% thus far using this technique at this institution. Okay, so in this, for this approach, what we'll do is position the patient semi-prone. This means prone, propped up on some towels or a pillow with their arm abducted. You'll palpate the back of the acromion. Here's the radiographic anatomy of what you're looking at. You have the humeral head, the glenoid, and the back of the acromion here, and you can see the arrow pointing to the posterior aspect of the glenohumeral joint. The ultrasound will be parallel to the posterior margin of the acromion and just inferior to it, and you look for that same anatomy, the back of the humeral head, the back of the glenoid, and in between them, the posterior labrum. Here's the corresponding ultrasound anatomy. We have the humeral head, the labrum, and the glenoid all in view, and our needle is going to go right in between the humeral head and the labrum. So here's the approach that we're using. I assure you I did not actually perform a procedure on this day. We just took a photograph so I could show you technique. I do always use sterile gloves when I do these procedures. We use a freehand technique somewhere between a 5 megahertz curved transducer and a 12 megahertz linear transducer, depending on the size of the patient. We use a lateral to medial approach with typically a 22 gauge spinal needle. Here's what it looks like. Humeral head, glenoid. There's my needle, and there's my needle tip. Now keep an eye on the yellow arrows. That's the joint capsule. As you inject, the joint capsule will begin to lift off and continue to lift off as you inject further. So that's what you're looking for to prove intra-articular fluid. And you can see the fluid surrounding the labrum. Much easier to see the labrum now after the fluid has gone into the joint. A tip for this injection. For large patients, I would just go straight to the 5 megahertz or 6 megahertz curved transducer. You're going to get much better depth penetration in the tissues. You'll be able to see your target. This also has the added advantage when you're going through a lot of tissue with a needle, you'll have a more oblique course, and it'll be more difficult with a linear transducer. With a curved transducer, you see your needle more easily. So this will help you in two ways, depth penetration and needle visualization. Here's a recent example just within the past week. We didn't access the joint with this, but what we did is aspirate a spinoglenoid notch cyst. Here's the MRI. This is a 28-year-old male with shoulder pain and mild weakness on external rotation. You can see the large lobulated spinoglenoid notch cyst, and on the right image, intramuscular edema throughout the infraspinatus muscle. Here's the ultrasound image showing the spinoglenoid notch cyst, and on the right you can see the suprascapular neurovascular bundle has been displaced medially by the cyst. That's what we want to not stick with our needle. We used exactly the same approach I just showed you, but came a little more medially and got our needle into the cyst, and we got very thick, viscous, yellow, jelly-like stuff out of there. It was very difficult to aspirate even with an 18-gauge needle. We ended up lavaging it with 1% lidocaine. We reduced the size substantially, and there we are at the end after aspiration. We did inject some corticosteroid into the body of the cyst afterward. Okay, we're going to move to the acromioclavicular joint. The acromioclavicular joint is an easily identifiable structure. You can palpate it. For ultrasound, you can put the probe right on top of it. And here's your radiographic anatomy of the acromioclavicular joint. Corresponding MR anatomy. On the left image is a coronal image of the AC joint. You can see the superior capsular ligament shown well, and also the inferior capsular ligament. On the right image is an axial image. In this case, you can see a little small anterior capsular ligament as well. Corresponding ultrasound image. In this case, there is fluid within the joint. The superior capsular ligament has been lifted off a little bit. The AC joint is very easy to find by ultrasound. Indications to inject it are similar to what we talked about before for the glenohumeral joint. Osteoarthritis or inflammatory arthritis are the typical, most common indications. Accessing the joint can either go short axis or long axis of the joint. Either one is an acceptable technique. Here's an example of a long axis along the clavicle. You can see the needle entering to get into the joint. So fairly easy to get into the acromioclavicular joint. You're only going to be able to inject about 1 cc in that tight joint usually. If we want to get into the subdeltoid bursa, it's very easy. You can palpate the acromion, put your ultrasound at the edge of the lateral edge of the acromion. You're looking for this anatomy. On the coronal MR, you find the acromion. You see the little sliver of fat in between the deltoid and the rotator cuff. That's where you're looking for on the ultrasound, and that's the approach that you will take with the needle. Here's an example of a large amount of fluid and synovitis, inflammatory tissue within the acromial subdeltoid bursa. And in this patient, we had the patient lying with the opposite side down decubitus. The probe is just lateral to the edge of the acromion, and the needle coming long axis of the arm to get into the fluid collection and aspirate. Okay, and the last procedure we'll talk about is calcific tendinitis. Remember, calcific tendinitis is quite common in the general population. It is predominantly hydroxyapatite in nature. It is most commonly affecting the supraspinatus tendon and to a lesser extent the infraspinatus tendon. Ultrasound is highly accurate in the diagnosis of calcific tendinitis. You can see on the right image the radiograph showing the toothpaste-like calcification. On the right image, you can see the echogenic calcification within the rotator cuff tendon and a little bit of posterior acoustic shadowing behind it here. The cortex looks thinned out because of the loss of some of the sound waves bouncing off this calcium and not going through. That's a poor man's explanation of what Dr. Berry explained earlier. Okay, so different techniques have been utilized. Some authors have advocated using two needles, one to inject and break up the calcium and the other to aspirate. We have typically used a single needle technique here. We put the needle right into the calcium deposit, we lavage with 1% lidocaine, and we aspirate. We do this repeatedly. And then at the end, we inject either methylprednisolone or triamcinolone into the cavity and into the residual calcium. You'll generally not be able to get all of the calcium out. This is an example from within the past year in which the patient came in. You can see the same radiograph I just showed you with that toothpaste-like calcification. There is still some residual calcification after the procedure, but is markedly reduced. And this patient had pronounced pain relief from this injection. In general, the published data on this says that patients have significantly better outcomes in the early stages and intermediate stages of time frame after this procedure. After about a year, once you get to 5 years and 10 years, they did not have significantly different outcomes compared to controls. So it's an early to intermediate level pain relief procedure. Okay, so in summary, ultrasound is the modality of choice for the biceps tendon sheath injection. It is also useful for joint and bursal injections about the shoulder, and we talked about some of those techniques. There is a growing body of literature regarding chondrocyte toxicity from intra-articular anesthetics and corticosteroids. Please be aware of that and watch for that, because that continues to grow and that will guide our clinical practice. Ultrasound is highly accurate in the diagnosis of calcific tendinitis. Lavage and injection of calcific tendinitis provides prompt symptom improvement and improved outcomes for up to about a year. Thank you.